Part 2 of the theories of psychosomatic illnesses, and we are going to proceed and now focus on the biomedical aspects. Okay, so in the first part we did the psychodynamics model. We did the three aspects associated with the biomedical model. We also did look at the Biopsychosocial Model, and we'll now proceed then look at we'll start with the Freud's Psychodynamic Model, which is just in the human mind conceptualized in terms of the conscious mental processes. As we said earlier, that they are just the awareness of the mental events, thoughts and feelings, and the ability to recall them. But with subconscious mental processes, there are thoughts and feelings that are outside awareness and you can't remember them. So that is what we said according to Freud's psychodynamic model. Then so we also have the preconscious mental processes. So preconscious, as the name itself suggests, pre means before, so before conscious. So preconscious mental processes, they just describe the unconscious material capable of which are capable of entering the conscious. So that is the pre-conscious mental processes. They're just there to describe the unconscious material capable of entering the consciousness. Then we also need to take note of the core clinical features of psychodynamic theory, which are there to emphasize the essential learning aspect as associated with the memory. Then it is there also to provide the biological mechanical information or biological mechanisms that strongly support this facet of psychodynamic theory. Then when we talk of treatment in terms of vaccination, surgery, chemotherapy, it could be radiotherapy, aims, they are just there to change the physical state of the body. So treatment of such nature aims just to change the physical state of the body, and the responsibility for the treatment is based on the medical profession. So if the doctor suggests that for this particular sickness it is best to give a vaccine or to do a surgery, or maybe you need a radiotherapy or chemotherapy, that would be the decision of that medical professional to suggest what is needed so as there can be a proper medical attention. Then in biomedical health and illness, these are seen just as qualitatively different, but we can say that they're either healthy or heal, and there is no continuum between the two. So in biomedical health and illness, there is no continuum between the two. They're just referred or seen to be quantitatively different from the other. So either one is healthy or ill. So that is what we need just to understand there. Alright, so as it is stated in the episodic memory, that this kind of memory can be poor or non-existent. So as we did earlier, we said episodic memory is that kind of memory which you are able to remember through a series of events. So it is poor and non-existent before the age 3 due to the inadequate hippocampal development. Yet epigenetic research is there to confirm that stressful experiences that occur even shortly after birth, we can talk of maternal separation, can have a lasting effect on the hypothalamic, pituitary, and adrenal axis, also known as HPAA. So we know that this mechanism, hypothalamic, pituitary, adrenal axis, is there to regulate the stress response into adult life. So the data support psychodynamic claims regarding the importance of early experience. Now, when you're talking about the traditional psychodynamic theory, it has been particularly prominent in the explanation of conversion disorders. So when you're talking about these conversion disorders, they're just unconscious intra-psychic conflict. It could be a wish or just need. So that is where the term converted or conversion rather is coming from into somatic symptom, which presumably now are able to be expressed and we're able to see them, and at some times protecting the person from now the conscious awareness. Right, so the neuroscience has rediscovered the reality of unconscious processing and has demonstrated that the iceberg analog may all be corrected. So it is suggested that as we looked at this iceberg analog, we said 90% of the brain processing is just unconscious, but only 10% is conscious. So we did this iceberg in the previous session. Then when we look at how the brain is divided, the brain has two major aspects. There is the conscious mind and also the subconscious mind. Then under the subconscious mind, we have what is known as the ego, superego, and the id. So these are the major concepts we need to understand what it means when they say id, ego, superego, conscious, unconscious mind, libido, and also anxiety. Alright, so when you're dealing with the psychodynamic model, it is important to take into consideration the psychiatric mental health. But even before we can look at this, let me just explain on these concepts. I think we did them in the previous session, but for the sake of explanation, let's try to understand what they mean by id, ego, superego, subconscious, unconscious mind, libido, and anxiety. So when you're talking about id, we'll try to break this in simple terms. id is just the baby part of you. excuse me, that is the meaning of ID. So it's all about instinct, the drives, the pleasure seeking. So I'll take an example whereby you're just there and you say, this is what I want, and I want it to be just here right now. So that is ID. So it just wants what it wants, and it wants it just there and then. That is ID, that baby part of you. So for this ID, there's no logic, there's no morals, there's no delay. That is ID. Okay, and one thing we need also to take into consideration is that this ID, it is 100% unconscious, and it is just present from the time a person is born. Then there is now the drive that is able to cause this ID. Something which is going to drive you is what is known as libido, the fourth point, the fourth concept rather. So this libido now, it will be more like the main energy of this ID. So what this libido is going to do is just be there to be like the life or maybe the sex drive. So that is just like a drive that is going to cause this ID. So it's more like a sex drive or something like a life drive, something that is going to push you. The energy for this ID is what is known as libido. Then when you're talking about the ego, this is now the manager. So with ID we said the baby part of you, but when you're dealing with ego, the ego is more like now the manager part of you, something that is going to help you deal with the reality. So this is what is now going to help you to balance your ID edges. Those edges like I want it now, I want this. So what is going to manage that is what is known as ego. So it is there to balance now your ID edges with the real part of the world. And one thing we need to understand about this is that this is mostly conscious, and sometimes it can also be unconscious. Okay, so I can give an example on ID and ego. So let's say your ID wants something, like your ID says, eat this whole cake, eat the entire cake. That is your ID. But your ego, we said it's your manager. So it's now going to tell you, you can't eat the whole cake, but you have maybe one slice after dinner, so that you don't just feel guilty. So that is your ego. So your ego is going to manage that ID edge. Then when you're dealing with the super ego, just like the name itself suggests, we say this will be like the parent part of you. Okay, so it deals mostly with conscience. Let's say your ID is your baby part of you, ego, it's a manager part of you, then the super ego will be the parent part of you. So this one will be dealing much with the morals, the ideas, the social rules, and also it is the one which is going to bring about the judgment to make you feel guilty about a certain thing that you have done. So the example I can give here is that okay, for I can take the same example. The ID says eat the whole cake, but your ego says have one slice instead of the entire cake. Then your super ego now, since it is the parent part of you, it will be there to tell you that you shouldn't have the whole cake, or you shouldn't have the cake at all. So diets are about discipline. Like, it will be there to make a certain judgment on you. Like, it will be judging you about a certain cause. So that is one thing you need to understand there. Then about conscious and conscious mind. Conscious is just what you are aware of, what you are aware of right now. That is your conscious part of the mind. So with conscious, when you're reading something, that is conscious. You are noticing that you are hungry, that is conscious. Maybe you are deciding whether to go out and hang with friends, or maybe you are deciding to take someone. That is the conscious part of you. But the subconscious, or should I call it the preconscious part of you, is the stuff that is not in your mind right now. So this could be your memories, your knowledge, which is just stored, or any information stored in your mind. That is your subconscious part of you. Then we know what anxiety simply means, so I won't spend much time on that. Okay, so under this psychodynamic model, we said that there are important things we must take note of. So one thing is the defense mechanism, the interference and the counter interference, and also not forgetting the interpersonal relationship with patients. Okay, so these are what we need to take into consideration. So the psychodynamic model is just there to produce what is known as the therapeutic effect. Okay, and that therapeutic effect is what is going to be greater to control you, or sometimes bring about what is known as cognitive behavior therapy. Okay, so individuals with therapies of approach are used for enhancement of personal growth. For example, neurotic disorders that affect the motor neurons, or maybe the sensory part of you. So they are easily explained using this model, which is the psychodynamic model, because they are considered to be part of the psychological conflict. Then the issue of stigma is identified to be one of the major problems in health mental care, and this should be addressed by every nurse or every health practitioner in that multidisciplinary team. So with this stigma, the health practitioner should make sure that they are able to reduce the burden of the mental illness and also provide access to care. Other than that, they should be able to educate their patient about the etiology, symptoms, and also the treatment of the mental illness. Okay, other than that, they should also foster the development of the insight. Apart from that, they should be there to strengthen the patient's ego, interpersonal skills, communication skills, and also enhance the adaptive functioning in a large environment. Then the other model we should take note is the behavioral model. So this was developed by Anderson in the late 1960s, and this one fostered the framework for healthy service utilization. So its focus was just on the family as a unit of analysis. Other than that, it attempted to understand why families use health services to define and measure the access to health care. That is the behavioral model. Then the other thing which this behavioral model came up with was just to facilitate the development of certain policies that are there to promote access to health care, okay, and also enhance the behavior through the examination of the individual's attitudes and also other attributes. Okay, so the other thing which this behavioral model came up with, okay, was just it was just to bring about the basic interventions on the behavioral theories in the widespread psychiatric nursing. For example, it was there to bring about patient education, teaching patients on how to cope with the skills for their symptoms and also the mental effects. Then, other than that, it was there to change and entrenched habits, which involves like helping patients identify what motivates them. Other than that, it was there to help patients identify how new learned lifestyles can be there to become the permanent part of them. Then it also focused on the intervention, which included the privilege of systems and also the token economics. Okay, so it specifically came to understand or make patients aware of their socio-economic status and also ethnicity. It also focuses on the making this medical care to be accessible to any patient. So, as described by Joe Big in 2000 about the behavioral model for vulnerability populations, which just applies to the original behavioral model of healthcare use. So, this is underserved groups to identify challenges in obtaining the needed health services in order to promote improved access and also improve the health status. So, one thing we need to understand there is that there was predisposition or vulnerability that included social structure, and these were one, acculturation. So, with acculturation, this was just the process of culture and also the psychological change that take place as a result of contact with other cultural groups or maybe members from a different culture. Then also, it also focused on the immigration status, people coming from different areas entering our country or our societies. Then also on the living conditions, on the literacy levels, and also personal resources, insurance status, affordability of the medical care, and it also focused on the income, receipt of public benefits, competing needs, and also availability of the information. Then when you look at the cognitive model, this, as we said earlier, cognitive deals with how a person is able to think. So individuals can learn to identify and modify their distorted beliefs, their basic understanding of themselves, their world, and other people. So these distorted beliefs influence their processing of the mind, the information which they input into the mind, and also to give rise to the distorted thoughts. So this cognitive model was able to explain the emotional, physiological, and the behavioral resources or responses rather that are mediated by the perception and influenced by the beliefs and the characteristic ways of interacting with the world. So therapists were using this gentle psychological questioning process to help patients just to evaluate and respond to their automatic thoughts and beliefs. So what this was being done, like they were trying to teach them on how to engage and evaluate some processes just by themselves. So other than that, these therapists were also there to help these patients design the behavioral experiments so that they can be able to carry out certain test cognitions. Then when you're dealing with the health model, this is there just to give an approach on the change which has been formalized in certain specific theories, like the intervention on how a certain disease can be healed, the preventive measures which can be taken into consideration, and also what would be the side effect after that psychosocial illness has been dealt with. So according to this model, the health model, this was being practiced especially by the healthcare practitioners so that they're able to practice some health behaviors. And the health behaviors depends on two factors. One, it is whether the person perceives the personal health a threat, or whether the person believes that a particular health practice will be effective in reducing that stress. So the first thing is to understand if the person perceives a personal health threat. Okay, so if a person perceives a personal health threat, and also the other factor, whether the person believes that the particular health practice will be effective in reducing that stress. So it's just about a person perceiving the threat and also knowing whether that threat, whether maybe the health measure they are trying to put in across will be there to reduce that threat. So under perceived health threat, there is that perception of a personal health threat which is being influenced by these least three factors. The first one is the general health values. Then this is just about the interest of doing something that is in the best interest of the patient. So there is general health values. Then there is the concerns about the health and also the beliefs about the consequences of the disorder, just as we said earlier. And there are examples here. People may change their diet to include maybe low cholesterol, since we know that cholesterol can bring about the occlusion of the coronary arteries, then bring about some certain disorders. Okay, and also they feel of being threatened by the possibility of maybe a certain heart disease or a condition and other factors. Then we also have the perceived threat reduction. So under perceived threat reduction, this is where now a patient believes a health measure will reduce the threat. And there are two sub-components. One is whether the patient thinks the health practice will be effective, or the man who is considering changing his diet to avoid a heart attack may believe that the diet change alone would not reduce his risk of heart attack. So those are perceived threat reduction. So with the enjoyment of the life too much to justify taking those actions, so if it is perceived, if even his perceived vulnerability to heart disease is great, he would probably not make any changes because he has believed that even if they can change their diet, the diet alone cannot reduce the risk of having heart attack. Okay, so this is where this topic ends. The topic to do with psychosomatic disorders, this is where it ends. and don't forget to subscribe. Thank you for watching part 2. If you didn't watch part 1 or if you missed it, check it out on the channel or on the app so that you are updated.